Hello, everyone. My name is Christian Ramey. My pronouns are she, her, and I'm the co-president of the Maternal and Child Health Student Interest Group here at Iowa. Claire Carlson is the other co-president of our Student Interest Group, and Catherine McDonald is our communications director. And we all want to welcome you to the event today. Again, thank you for joining us for the Spotlight webinar on equity in epidemiology, improving maternal and child health outcomes through research. A very special welcome to our three speakers, Dr. Mira, Sheff, Dr. Erica Fuchs, and Dr. Debra Kane. We wanted to take a moment to thank the folks that made today possible. This event is brought to you by a collaboration started by our very own Avi Ramesh, and was supported by the University of Iowa Maternal and Child Health Student Interest Group and the University of Minnesota Center for Leadership, Education in Maternal and Child Health Public Health, and the University of Minnesota Maternal and Child Health Student Interest Group. Before we get started today, we want to take a moment to acknowledge the lands that we are on. While we're gathered here together virtually, it's important to acknowledge that no matter where you are in the United States, you are likely situated on the traditional, ancestral, and contemporary lands of Indigenous people. We encourage you to learn more about whose lands you're on, and the link that I'm going to share in the chat can be helpful in supporting Native communities at the local level. So again, thank you so much for being here. I am now going to turn it over to our speakers for today and give them the opportunity to introduce themselves. So Dr. Sheff, you can start us off.
All righty, thank you very much for inviting me here. My name is Mira Sheff, pronoun she, her. I'm the state maternal and child health epidemiologist in Minnesota. I've been here since about 2015. In this role before that, I was an assistant professor at SUNY Downstate Medical Center in Brooklyn, New York, where I did research on balancing work and family after childbirth and for working populations. The work I do now, I assist with the Maternal Mortality Review Committee here in the state. I'm principal investigator for Minnesota PRMS, the Pregnancy Risk Assessment Monitoring System. I sit on the Minnesota Perinatal Quality Collaborative Steering Committee and vice chair of their data committee. And we can maybe get into some of that other stuff later. I did my training at the University of Minnesota in environmental and occupational health and my PhD in occupational health services research and policy. So, and that blended epidemiology with health services research. And so that work tied into work-family conflict balancing, work and family after childbirth, which pulled me into the MCH arena. So anyway, thanks.
I'm Erica Fuchs, the CDC Maternal and Child Health Epidemiology Assignee to Nebraska. In my role, I function as a senior epidemiologist supporting the Nebraska Department of Health and Human Services in a variety of ways, from data analysis and subject matter expertise to technical assistance and mentorship of students and junior staff. I've been with CDC since September 2020, and prior to that was an assistant professor at the University of Texas Medical Branch doing women's and children's health research, primarily in vaccination and behavioral predictors of vaccination. I have an MPH in maternal and child health and a PhD in epidemiology, both from the University of Minnesota. Similar to Dr. Sheff, I also work with our Maternal Mortality Review Committee. I'm the PI of Nebraska PRAMS and do a lot of work with our COVID-19 SetNet module, which is the way that we surveil women and their pregnancies after a COVID infection. Thanks very much.
Good morning, and thank you for inviting me to this presentation. My name is Debbie Kane. I'm at the Iowa Department of Public Health. And like Erica, I'm maternal child health epidemiology assigned to the Iowa Department of Public Health by the CDC. And my background is quite varied like the other panelists. I do have a background in public health nursing, and that's really what brought me into maternal child health and an interest in research and policy. And some of my major projects, like Dr. Sheff, I work with the Iowa Maternal Quality Care Collaborative, developing data dashboards to support that. I worked as a public health nurse for a long time. And unlike Dr. Fuchs and Dr. Sheff, I don't typically work with PRAMS. However, I do have the opportunity to work with other data sets like vital records, as I'm sure they also do with the hospital discharge data file. And I'm sure you'll have more questions about this. But one of the richness of working at the Iowa Department of Public Health is the availability of data and to use that to inform policy and practice. So I will leave it there, and I look forward to hearing your questions and having a really exciting conversation. And one last thing, I do want to acknowledge the ancestral lands here in Des Moines, and those are of the Iowa people, the Sauk, and the Meskwaki peoples. So thank you so much. Looking forward to our conversation.
Well, thank you all for those great introductions. We are going to get started with our student questions. Paul, do you want to get us started? And then folks who are attending the session, if you have questions for our speakers, you can throw your questions in the Q&A chat, not the regular chat. And so we can record your questions. So thank you so much. And Paul, you can take it away.
All right, absolutely. So again, thank you so much for our panelists for being here this morning. And I will go ahead and start us off with our first question. So this first one is actually twofold, and I'll be posting it in the chat for reference as well. So we'll go ahead and start off with, what are the most prevalent maternal child health issues in the Midwest when compared to other parts of the country? And are there any specific political or financial barriers to performing MCH research in the Midwest?
All right, I think I'm kicking this one off. So I don't know if the issues that we're facing in Minnesota are necessarily different from elsewhere in the country. I think a lot of the states are facing the same problems. I just think the magnitude might be a little bit different here. So the main things I know we're focused on now would be, maternal mortality, infant mortality, early childhood development, referral and access to services. These are the big things. And something that isn't necessarily unique to MCH, but is really hitting our MCH populations really hard, is substance use disorder. That's pretty common across the country, but we're seeing really it's hitting our communities hard. So again, I don't think Minnesota is necessarily unique to that, but the disparities that we see here with our populations of who's being hit hardest, that is pretty large here in Minnesota. I think it's pretty well reported that we have some of the largest disparities in the country, with our American Indian and African American populations being hit really hard. Specific political or financial barriers, well, there's never enough money, right, to do the work that we want to do, to fund the research that needs to be funded. We would love to hire more EPIs to help with that, but that's not really possible for us right now. Political barriers, yeah, I don't want to dive too deep into down the political rabbit hole, but to say that we definitely have some challenges here with divided government and sides not really seeing eye to eye with how to address some of these issues. But I will say that last year, I don't know what's going to happen this legislative session, but last year we had a number of wins, significant wins. So we had expansion of Medicaid for up to 1 year postpartum that went through. We have the Dignity in Pregnancy and Childbirth Act, which requires continuing education for providers on implicit bias. And the first in the country is the Minnesota Healthy Start Act, which gives incarcerated people who are pregnant or give birth during their sentences the option to receive pre and postnatal care in community-based settings. So we're the first state in the country to have passed that. And there's also more dollars for school-based health programs and things. So all of those are really positive changes that are going to help support MCH outcomes in our state.
So I'll just add that a couple of special challenges for Nebraska is the closure of some rural hospitals and their OB units. So If you're not familiar with the population of Nebraska, the vast majority of people live on the east side of the state in Lincoln and Omaha. And so the rest of the state really has few birthing hospitals available to them. So we see many women going out of state to have their babies or having to travel really far to do so. So that's one challenge we have. Also, the formula shortage is currently a major issue, especially for our WIC moms. If they rely on a specific type of formula, they can have a really difficult time finding it right now. And many of these people also rely on or they might not have a car to drive to a Target or a Walmart that's a little bit farther away than usual to go find their child's needed formula. So that's an issue. We are sort of in the beginning stages of seeing how expanded Medicaid has affected our population, and I hope that we'll be able to dive into the results of that soon, and hopefully we'll see that good things have happened. There are always political and financial barriers. I don't feel super comfortable talking about specific ones in the state, but you know, we can't always get everything that we want. And so we have to balance those needs and priorities. And sometimes the state has specific priority areas or priority groups that they want to focus on during a certain time frame. And so we do our work with those in mind, as well as a CDC employee, focusing on the things that CDC finds important as well.
Well, I can build off of Dr. Sheff's words and Dr. Fuchs' words. We're seeing similar things in Iowa, where the difference is really the magnitude. But also, we recently did a strategic plan, and what came up from the respondents, both clinical, community, and public health people, are concerns about mental health. And really looking at how do we address mental health, both during the perinatal period and then postpartum. And as we consider Medicaid expansion, one of the things that is raised during that time is if people have Medicaid coverage postpartum, they'll be able to continue with some of the services that they receive for mental health during pregnancy, but also really looking at how do we screen for mental health and how do we address that. And I remember one of our previous Title V directors said, you know, it's mental and dental, because also access to dental care is a real challenge. I would imagine in both Nebraska and Minnesota, when you look at the size of the state and the availability of dentists, many dentists don't accept Medicaid, and that's a real challenge. And when you think of, you know, chronic inflammation and believe it or not, but the mouth is part of the head and part of the body. So how do we keep all those things together? But really some similar things in terms of OB units closing. Why are they closing? How do we support other mechanisms of perinatal and prenatal postpartum care and that sort of thing, and keep the skills up of the hospitals where fewer babies are delivered? Let's see. Just, you know, in terms of wins, like the other panelists, I think as government employees, we really need to be cautious about how we speak about politics, but there is a real interest in birthing and maternal health at this time in Iowa. So we really want to capitalize on that. And in case I don't get a chance to say this, just in terms of politics, you all can vote. So register to vote, be a part of the process. You know, that is not tied to any political party. That is something that you can do. And, you know, in Iowa, there's a primary in June. This is an off-year election year, but that doesn't mean you should take the year off. So I just want to advocate for voting in all elections. So can move on from here. Thank you.
Thank you guys so much. That was, I think, better defined this topic for our participants today. So our next question, Claire, do you want to start us off with a conversation about PRMS?
Yeah. So our second question today is, what has been your experience using data sets like PRMS and vital records as an MCH epidemiologist? Are there any changes you would like to see with these data sets going forward? And what types of data sets would you like to see in the future?
All right. So for PRMS, in terms of using it, I think, as PI, our experiences are going to be somewhat unique in that we have access to the data. We can analyze it anytime. It's very easy for us to get it. But I know that sometimes it can be challenging, and I recognize it could be challenging for people trying to get access to it who don't have ties to the program. But at least in terms of that, it's like, my personal focus is always on the data collection process and the limitations around that. And so a change that I would love to see for PRMS is that it be expanded to being more than English and Spanish, but it be offered in other languages that for populations that we see here in Minnesota, like Somali, Karen. I mean, there's a long list, but that's expensive to do. And right now we don't have the ability to do that. One big change that's happening now, and we're testing it, is that we're going to move to data collection. There's going to be a web module. So for those who aren't familiar with PRMS, it's like, first we mail you a survey 3 times, and if you don't respond, then we move you into the phone phase, and then that's kind of it. But that doesn't really work as great now as maybe it did back in the early 2000s. So they've just, we are piloting now the web module. We've done some user testing, and we're really excited to hopefully roll that out in the next few months. And hopefully that will improve data collection. Hopefully that will help improve response rates. So that is a positive change. Another change that's happening that's going to help with user access, researcher access to the data, is that they're moving from a proposal-based data request process to one where you can download websites directly from the web, which will be great. You just have to fill out something. I think it'll be similar to some other data set CDC houses like Purpose. And you can just download that and analyze it. You don't necessarily have to reach out to individual states. You might, depending on the variables you need. And if you do that, then it can probably take you a few months to get access to the data set. But if you can avoid coming to us, then you can get the data right away. And then that will be really helpful too for research purposes. So that'll, I think, happen sometime later this year as well. Yeah, I think those are the things I can think of right now.
So I think I'll speak sort of to the student perspective. So I actually used Minnesota PRMS for my dissertation, and I used Minnesota PRMS and had that linked with MIC, which is the Minnesota Immunization Information Connection, as well as Minnesota Vital Records. And the process to getting that data took 2 years. So from the start of my first meeting with the folks at the MDH IRB to me actually getting the data was a 2-year process. So if you're in a PhD, you have time. If you're in a master's, there might be other angles you might want to try, or just using one of those data sets. But I think that with PRMS and many of the existing MCH data systems, we don't necessarily always want to collect more data. We want to think about what data we can use and use innovative methods like linkages so that we can better use those data, because every time you're surveying somebody, you are using their valuable time, especially a new mom. You don't want to necessarily give them more questions. You don't necessarily want to burden them with another survey or some other requirement. So using that data was a very rich source of information for me. As far as vital records and PRMS data goes, every state is very different with how they release their data and the data that they protect. So Nebraska has specific statutes that do not allow us to release some of the vital records data, or if we do, it has to be after a certain time frame, and there have to be certain processes followed to be able to safeguard that data. Every state will have some sort of rules around that, but it really depends on what they have, what processes they have to go through. As far as Nebraska PRMS goes, we oversample Black and Native moms, and getting those response rates up has been a struggle. And so we end up having to combine years of data to be able to provide estimates for those groups. But we can't necessarily always be surveying more people, because we are, like I said earlier, burdening more people and, taking more time burden from them every time we ask them to do a survey. The web module will probably be a really amazing change, and I hope that increases response rates. But PRMS is a wealth of data. I don't know that I have specific recommendations for changes in the survey itself, but if you have a chance to use it, it's a great way to build up your data analysis skills and just get a better understanding of MCH.
So as I think I mentioned, I typically don't work with PRMS. I really tend to work more with the vital records for some of the activities around our Iowa Maternal Care Collaborative and some other reports related to vital records. And Erica brought up, I think, a really great point about linkages of data. And one of the things that I work on is linking the birth certificate to Medicaid paid claims, linking the birth certificate to the Iowa hospital discharge file. Again, no one single data set can answer all of your questions. So then how do we manage the burden of completing the information with how we want to gather data? So that's been one way within Iowa, and I know in other states too, Nebraska and Minnesota, data linkages play a really important part in that. But also in Minnesota and Nebraska, you heard about challenges about making data available to students and to researchers, and really every state is different. And I know there's people from the University of Iowa on this call who have been through our process. I worked with someone in Illinois at the University of Illinois, and it did take 2 years for her to get access to the data. By the time the legal counsel in Illinois sort of worked with legal counsel in Iowa, no matter what state you're in, you have statutes that guide what data is collected, how that data is used. You'll see in Iowa, if you look at the code, that we have really strict limitations around what is collected for termination of pregnancies. So you'll see for every data set that it varies bit by bit, but don't let that discourage you. I feel that we have a richness of data. I think the piece with it, and maybe we'll talk about this later, but when you think about your data set and how you're using it, how do you translate that into public health action? So I think that's a question you want to keep in the back of your mind. But the other thing, like if I had my wish list, one of the populations that we can learn very little bit about is in the postpartum period. We do get some information from PRMS, but that's really limited. If you think about that first year of life with this new family and a new baby, we have very little postpartum information. There is a reproductive health module in the behavioral risk survey, but we just don't get a lot of information about that period or about birthing people not around the time of having delivered an infant. So I guess in a perfect world, we would have all that information, but we don't. So as I picture, we have a lot of good information right around delivery and that time period, but we're missing pieces during that, say, those first couple of years of life and also postpartum.
Thank you so much. I know Catherine has the next question for us, and we sort of want to learn more about the role of research within each of your roles or within each of your positions.
Okay, so the next question is, what roles does your research play in community health efforts in your state?
So I kind of feel bad going first all the time. Anyway, I'll take a stab at it. So I guess in the work, I tend to make a distinction between surveillance, which is a lot of what I'm involved with, and research. I feel like they're pretty different. So, I mean, related, but different. So in terms of day-to-day work, vital records data and maybe some PRMS data, some of the data we can get out of our MMRC, the maternal mortality group, is we provide some of that to this group. It's called the Children's Cabinet. For those who don't know, the Children's Cabinet is out of the governor's office, and it's an interagency partnership that looks at a whole family approach to supporting healthy development of children and families. So the Healthy Beginnings is one area where we engage with them, but there's other areas too. We use the PRMS data a lot for Title V work to kind of talk about what programming, is it working, is it not working, what might be needed. So that we use to inform our and report out for the MCH Title V block grant. And the Minnesota Perinatal Quality Collaborative is another one where we, I know Debbie talked about that before, but trying to share data that way so communities have access to it. So the MNPQC in Minnesota it's newer than I think some of the other states. So right now we're talking a lot about trying to get a dashboard up and running and trying to become an AIM state. So trying to get these guys access to the data. And it's hard. I mean, everyone else has already talked about it, but the data privacy laws, I mean, they're there for a good reason, but they also can make it challenging to do some of the surveillance that some people might think is more commonplace. It's like, it makes it hard. So, but trying to get access to some of that data so that can be used to inform the PQC's work. In terms of research, I am co-PI of this Office of Women's Health Maternal Death and Violence Grant. And this has this is good because it combines the maternal mortality surveillance work that we already have going on in the state as one arm of it, improving some of that and getting us access to other parts of data that we just got included in a statute last year that will give us access to some of the substance use treatment records and some of the other law enforcement records. So that's in statute now, which gives us access to that data. But then also with that grant, there is a treatment arm to it. It's called the CUES. Don't ask me, I can't remember what the acronym is. It's CUES, but it's an evidence-based intervention, and it allows us to expand that. And basically what the CUES intervention does is it helps to train providers in screening for interpersonal violence and referring that out. One of the things I can say we hear over and over again in the MMRC is that providers are like, you know, we know that we're supposed to screen, but we hate to do it because if they say yes, what do we do? So this intervention actually addresses that and helps to train providers in doing that screening, getting confidence in doing the screening and trying to then refer out. And it also makes some changes to that process to make it more culturally relevant and acceptable. So, and broadening that out to larger portions of the state. So that's exciting because, you know, with data collection and surveillance and research, it's like you talk to some of our community partners and they say, you know what, we've been studied to death. It's time to do something now. You don't need more data on us. You need to make the change. And so to be able to have this intervention piece and then study whether or not that works feels really good because it's like, okay, now we're actually trying to do something. We're not just studying the problem.
So I just want to say thanks to Dr. Sheff for sort of introducing the idea of a difference between a state epidemiologist and maybe an academic epidemiologist. So I'll just expand on that a little bit. When you're working at the state or federal level as an epi, you are typically not engaged in much research itself. Our role really is to report on the health, make recommendations for our population, but not necessarily to go chase down a certain hypothesis that you might be doing as an academic, which I definitely did as an academic. The role of a state epi is a little bit more about seeing what's actually happening in your state and being able to very quickly translate that somehow into a meaningful action or a recommendation for action. So some of the things that I particularly work on are using our state and federal data sources to help our WIC program, for example, see who they're serving. Are there missed populations that they're not able to serve for whatever reason? Coming up with the data sources and measures for the Title V needs assessment, which has to happen every so often. So hopefully most of you have heard of that. Our maternal mortality review committee reviews every single maternal death in the state. And from that, we compile the data and then we make specific recommendations for our providers and other folks in the state who are the relevant target of those recommendations. So for example, if we notice that many of the women who are dying during pregnancy or within the first year of delivery are dying from a specific cause, we might see, okay, what does the research say can help prevent these types of deaths? And then that recommendation is passed on to either the providers, the law enforcement system, drug addiction and treatment, things like that. Other things we do, compile reports upon reports upon reports for PRMS, vital records. Like I had mentioned earlier, our SETNet surveillance system, which is surveillance for emerging threats to mothers and babies. So that typically is syphilis, hepatitis, Zika, and now COVID-19. Other things that we do are if there is a very pressing matter occurring regarding MCH populations in the state, we might write a what's called a HAN, so a health alert advisory, and then send that out, and that would go out to the providers in the state and other interested people to alert them to some major problem in the MCH population or something that's affecting those folks. So as far as actual research goes, PRMS itself is technically a research project, but I view it primarily as surveillance myself. And yes, we can answer interesting hypotheses using PRMS, but it's also giving generalizable estimates of what's going on in the state. So I guess beyond that, I don't have a lot of research going on. Go for it, Debbie.
Well, thanks for really bringing those issues up in terms of applied epi versus academic epi. And I too, when I look at my work, I don't know that I call it research, but certainly there's a lot of surveillance. And even in for one data set, we are not allowed to do research. It specifically says in our agreement, we must do surveillance. So we really are cautious with that. But when I think about data and my role as a state API and MCH, one of the things that we actually do a lot of is quality improvement and looking at sensitivity and specificity around some particular outcomes. For example, looking at severe maternal morbidity, how well do the hospital records report what's going on, or looking at what data sources. We're working on a project now. I see Claire on, she's well acquainted with this, as is Dr. Rickman, looking at whether or not we can measure transfusions based on using the hospital discharge data. So we're using some other codes within that data set. So you get to do, I think, some really interesting QI activities. And Iowa was really involved quite heavily in the National Quality Forum's endorsement of contraceptive measures, those performance measures when they were initially endorsed in 2016 and then re-endorsed in 2021 using Medicaid claims data. So you might want to check out the NQF and the performance measures that now are part of the core measures that are reported to Medicaid. And with that, maybe we'll talk about it later, but a really important partner in my day-to-day work is a Medicaid, and that may be also true in Nebraska and Minnesota. But again, QI is a big part of, I think, that state.
Thank you so much. I know, Haley, you wanted to move us into a conversation about careers.
Yeah, so my question, and I'll put it in the chat here, for all the students that are on this chat, if the panelists could provide some, information on what do you think the most important skills for new members of the public health and specifically maternal and child workforce to have, and then any advice for future maternal and child health trainees on skills they should focus on or tips on navigating academic and practitioner partnerships.
So I think depending on what you want to do, there's a couple different areas I can think of. I mean, if this is epidemiologists, it's like, well, you gotta be comfortable analyzing data, right? You really get comfortable with that. So it's one thing to do it in the classroom, and then it's another thing to get a really messy data set that you're like, okay, what am I going to do with this? And then you develop an appreciation for all of the assumptions that go into cleaning the data set and what that can do out on the other end. But I would say be comfortable analyzing data. As many data sets as you can get your hands on, work on it. So that also means being comfortable using either SAS or, I mean, that's what we use mostly here at MDH, but some students come knowing R or SPSS2. There's a lot of talk about dashboards, So if you can gain some experience using Tableau, that's the one that we use here at MDH, but also Power BI is another that is used by our agency. REDCap is a way that it's a free program that we use for capturing data, as well as also maintaining some databases. We use it for some of our COVID work. We use it for some of this new maternal mortality grant we're working with. We're going to use it to capture and maintain some data. So REDCap is easy to use, but get familiar with it. Grants now are requiring an evaluation component, some more so than others. So if you can get some experience learning how to do a project or program evaluation, I think that would serve you very, 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 very well in this work. And also working, I'd say if you have an opportunity to work with diverse communities, that's important to hear other perspectives and how to try and incorporate that into the work and the stories into the work. I didn't say it before, but one of the big challenges we have with our maternal mortality data is that our numbers are very small. And so you can't apply typical statistical methods for doing much with it, certainly not on an annual basis. Erica mentioned it, you have to combine years. So one of the things that is being discussed more, it's like, how do you share the stories? Because that's often what can make the change. So getting comfortable with qualitative research as well would be very useful, especially for some of the things we work on, where, well, we can't necessarily run any fancy statistical methods, but if we can make use of the qualitative data, we can get the stories out there, and those stories often has the ability to change or to bring about the change that we're looking for. So that's what I can think of.
I just want to echo the importance of learning some statistical tool, whether it's SAS, Stata, SPSS, R, learn something. Our major workforce need in Nebraska for MCH is having MCH epidemiologists. There are many people who love the MCH topic area and go for a more programmatic sort of degree experience, but those epi skills are really what we are looking for, whether it's to help us with our data entry or whether it's to run some very basic statistics so that we can do the report. That's what we really need. Another thing that I would recommend is increasing or improving writing and communication skills. All of our products will eventually go through a communications department, but they're not the topic area experts. They are just looking for your grammar, for your punctuation. And what we really want is excellent writing from subject matter experts. So we pay a lot of attention to that. As I just want to touch on the partnerships and academic practitioner partnerships. So as a, at the state health department, we have relationships with the University of Nebraska Medical Center, University of Nebraska Lincoln, Creighton, and some other universities in the area. And we keep those going by relying on their knowledge and skills in certain areas, and meeting on a not too frequent, but somewhat regular basis to keep our relationships going. So one of the things that we recently did in MCH is we used our PRMS disability supplement data to put out a short 6-page report. In doing so, we were able to bring in subject matter experts from disability related groups throughout the state and at the universities, as well as disability advocates and disabled people themselves. And so in doing that, we were able to define our roles, like what do we need from the state? What do we need from our disability advocates and disabled people in writing this? And it gave everybody a sense of ownership over the end product. And it was a really fruitful relationship building experience for everybody. So that was one of the ways that we made sure everybody felt included throughout that process. And yes, it takes longer to do it that way, but I think you get a better product in the end. There's also a Q&A in here. As far as types of statistical analyses we do, I'm a Stata user. I can also use SAS, but I'm best at Stata. And I do very simple analyses the vast majority of the time. But what I do think about is, what do the data look like before I run my analysis? What's missing from the data? Are the missing data missing at random or not at random? How do I want to put these into groups if I need to do that? Do I want to dichotomize something? Those are kind of basic decisions you have to make in statistics, but those are a lot of the choices that we make and in our presentation of our data.
Well, I want to second learning some, or third, learning some sort of statistical software, and REDCap and Tableau. Those are really great things to have on your resume. Another thing is I kind of consider what are some skills that you might need, or what you're, the people that you're mentoring or the people that you're working with might be asking is survey question development. I'm sure you've seen surveys that have gone out and people have been disappointed by the responses. But when you look at the question, you think, yeah, probably should have a little more conversation about that. So to the extent to which you can develop some skills in terms of how to write a question, a good question, so that it is asking what you want to ask and giving questions that are meaningful. But I also want to second the conversation around qualitative work and developing some skills in that. Another skill that I think is really great is data visualization, because as you're preparing reports, you'll want to be able to visualize that data. I participated in a training, if you ever get a chance to do this, but Stephanie Evergreen, like, I will never do data visualizations the same, like it has changed how I'm doing things. So that's a really important skill. And she works with Excel, and if you learn everything you can about Excel, I mean, that is a really powerful tool in terms of analysis and presentation. But again, in terms of looking at what skills you bring in, I think those are really important. I also want to build off of Dr. Fuchs' conversation around partnerships. We have a really great partnership with the University of Iowa School of Public Health, and also with the medical college, and just in a number of different projects. They're able to do some of the academic research, and we as public health people can provide feedback and guidance so that we can say, well, how will we use this in program development? But they've done some really wonderful work that in my position, I'm just not able to get to, because I'm really focusing on more simple sort of analyses and developing reports. So I just can't impress upon the importance of that academic connection. And also, it's really important if you can find practicums and internships at your state health department or local health department. That also is a really important piece on your resume.
Cool. Thanks for all the great tips and sharing your experiences. But I think we're going to maybe move on to the Q&A portion. And it looks like we have 2 questions ready for you guys. I can copy the first question into the chat for everyone. So Dr. Sheff, if you can maybe get started, or anyone, I guess, at this point, if it's a Q&A, if you guys have a response to that, that'd be great. Yeah, so the first question that we have, and I posted it in the chat too, but it's, can you discuss any challenges or unique considerations associated with surveillance in rural areas?
I'll give someone else a chance to go first on this one.
So I'll just speak to our PRMS project. Many of our native moms in Nebraska live in rural areas, and they have a hard time getting their mail. This is a very basic problem, but mail routes, moving between homes, that is a unique challenge to Nebraska PRMS specifically. So we are going to try some different methods to try to make sure those people get their PRMS survey by working with community partners that have existing relationships with many of the folks in that population. So we're going to go through community health centers, make sure they're stocked with PRMS surveys, so that if some of our sampled participants come into the office, they can just pick up a survey rather than relying on USPS. So that is a very maybe unexpected but realistic surveillance issue for MCH.
I can say for our rural population, I mean, there's a few challenges, but the one that comes immediately to mind is those folks who live close to the border. North and South Dakota, they may not give birth in Minnesota, they may give birth in one of the Dakotas. And if that happens, believe it or not, we then have some challenges getting hold of that birth record. And how we can use that data is very greatly affected. I mean, we just, for a while, we didn't have access to our out-of-state birth data, which, for most of the state, it's not a problem. But then if we're missing folks in the Northwest or, in the western half of the state, then we're not getting accurate counts or infant outcomes. We were missing some of the infant deaths too. We were. Our OVR was getting that, but they weren't able to share it with us until we went through some steps to get access to that data. And now we've got it, but then we can't use it for like identifying a mom, for example. I mean, we can run analyses on it, but we can't use it for identification of any maternal deaths or anything like that. So that is a challenge. Also, I'd say not specific to rural moms, but if we have a Minnesota resident who dies out of state, then we may not find that case. So that really impacts our maternal mortality surveillance because states don't share well with each other. We need some overarching rules to make that data sharing easier across states. Otherwise, I mean, as it stands now, we would have to set up an agreement with all the other states to try and get access to that data. And that, I mean, very lengthy process.
I think Iowa sees a similar issue. There's a county in Southwest Iowa where 50% of the deliveries occur out of state, mostly in Omaha. And so record information through interstate agreements, but we're missing information on access to prenatal care. And when we look at the hospital discharge data, that's limited to state residents. So at some of our hospitals, about 25% of deliveries are to women who live out of state. So if you look at, for example, calculating severe maternal morbidity, our numbers are relatively low. And in some hospitals, they're missing 25% of the cases. And, you know, there's interstate agreements around sharing vital records. Those types of agreements do not exist, particularly around hospital discharge data and state level hospital associations. So it's not specifically rural, but just, you know, when you think of in each of our states for maternal mortality, for example, or infant mortality, our numbers are relatively low. In Iowa, it might be 10 or 12 maternal deaths in a year. And if we're missing even one or two, that really changes our rate and can tell a really different story. So just, you know, how do we investigate data sharing, recognizing there are some proprietary issues related to data, but it can influence what our data looks like, especially when you look at families that live near other states or travel to Omaha, travel up to Mayo, and that sort of thing. So again, not specifically rural, but a data concern.
Thanks.
Yeah, I just want to echo
sorry.
the statutory authority that was mentioned. We cannot request records from other states and expect that we will actually get them. We have statutory authority within our own state to get specific records to review deaths or serious illnesses or injuries for MCH related populations. So like Debbie and Mira both said, we are missing some of those cases and we might not know about them. As far as the current pandemic goes, we've had this issue with identifying MISC cases. So if one of our kids goes to a hospital that's out of state and gets diagnosed with MISC, which is a post-COVID complication, we might not be notified of that by the out-of-state hospital. And so we have to chase those down when we find out about them, but we might miss them or they might be reported by that state rather than us, who we should be the ones reporting them, but that's not always how it works. And that goes with vaccine records as well for children. So if you have kids who were born in another state and raised there for a few years, and then you move somewhere else, your vaccine records do not follow you unless your new provider puts them into the immunization information system for that state. So sometimes there are inconsistencies, or it might look like a child has never had a vaccine, but they're just, you know, not in the system correctly for whatever reason. It just didn't make it in there. So again, not rural, but some data issues with moving between states.
Okay, awesome. Thanks for answering those questions. It looks like we might have time for just one more. So the next question is kind of what is the conversation around non-paper survey methods, perhaps using phone from the beginning or online? And I'll copy it into the chat.
I can start with that. Just, you know, I know, but both Erica and Mira talked about PRMS, and even though it's mailed 3 times and it goes to the phone phase, our phone response rates are really dropping. And it's really exciting to hear that PRMS is investigating an online survey. That'll be really wonderful once that gets, you know, up and running. And so many people don't necessarily have a landline, or, you know, if we're doing a random digit dial, like maybe I'm really dating myself, but thinking back to the National Immunization Survey, you know, some of those surveys that are random digit dial, that just doesn't work anymore. Or people have, you know, you can see who's calling and you can decide not to pick it up. So that is really a challenge. So I think we really, just need to investigate other ways to reach people. You know, one survey that we have that I didn't talk much about is our barrier survey, which is on paper, but is distributed in the hospital. So what are other ways that we can reach families so that they're not getting something in the mail and or when they're going in for their postpartum visit? I mean, PRMS has a really strict protocol, but could that protocol be revisited to reach moms in all different ways, whether it's paper, phone, or, you know, many different options? So it's an ongoing conversation for the big national surveys as well as the state surveys. So I don't have an answer, just more questions.
Yeah, I guess I can throw in there too, you know, just like what does the conversation around the non-paper look like? I don't know exactly. I mean, you know, when I first started here, CDC had been talking about a web module, and I think they had been talking about the web module like for a few years, even before that. So the fact that it's finally happening, I mean, there is much rejoicing happening across across the states for this. However, I want to say that we aren't under, I mean, we hope that it helps with response rates, but we don't know. We don't know what's actually gonna happen. There are, I can't remember if it was North or South Dakota, they actually did a PRAMS-like survey and had a web component to it. And there were challenges with that, right? There's going to be new challenges with trying to roll this out, getting the email addresses. You know, I mean, they've created it so that it should work on a phone or a tablet. Like you don't have to sit at a desktop computer, which is good because most people aren't doing that anymore anyway. But, you know, it will hopefully help, but I don't think it will be like a cure-all for the response rate problem. But it's definitely a step in the right direction, looking at alternative methods. So for getting the surveys into the hands of people, I think in some states has been the most successful, especially our hard to reach populations, American Indian populations, working with tribal nurses who can hand deliver that, or working with WIC offices and having them available there. These are all things that states can do. But you have to go through like a special process to try and do that alternative method. Anyway, we're hopeful that the web module helps us, but without a doubt, there's going to be some challenges with this method too.
I'll be really brief in answering this one, but I think our major issue is making sure that we've actually targeted the right person here. And so because we don't collect email addresses, we can't just go straight to email. We have their physical address and typically their phone number. And so that's where we have to start. Web surveys are notorious for spam and fake answers. And so making sure that we are linking the right people's vital records to the correct PRAM survey response is very important. And we can do that with the existing survey methods that we have. And hopefully with the web-based survey module that comes out, there will be some type of code or something like that to make sure that we have the right person. But going straight to a web-based module without contacting them through phone or through their home address first seems like it would be ripe for spam.
All right.
Totally agree. Totally agree with that.
Okay, well, we are pretty much at time. I just wanted to take a second to thank you so much to all of our speakers for sharing your experiences and insights. And thank you to everyone who attended and made this event possible today. Again, a special thank you to everyone. And I hope you have a wonderful rest of your week. I am going to go ahead and stop recording. And again, thank you so much.